Registry and Biobank, which is actually co-led by Larry and I. The aims of the registry are to collect very good quality, in-depth data in patients with NORSE and FIRES to determine the cause, describe the clinical picture and the natural course of these entities, with a focus on outcome and determinants of outcome, including, which is something that hasn't really been done in the past, long-term outcomes, long-term functional, cognitive outcomes, and quality of life, which we felt are important endpoints that haven't been addressed in past studies. The other goal is to determine the best treatment strategy for these syndromes. Of course, it's an observational study, so we won't be able to do a real controlled trial to decide which drug is best. But with the data we're collecting, we should be able to run what we call comparative effectiveness studies. So in real life, comparing what doctors have done in different cases, trying to see if one strategy, one treatment emerges as better than the others. And these data should prove very useful in the future when we want to design a randomized control trial. So it will generate hypothesis, kind of design the best drug candidates for a randomized control trial. And the third goal is to collect biological samples. Then we're going to store for future research, trying to unravel the etiology of NORSE, as you have heard about yesterday during the scientific symposium. So the methods, it's a prospective multi-center observational registry. We are prospectively collecting data from a huge number of centers. The study started within a consortium called the CCEMRC, Critical Care EEG Monitoring Research Consortium. It's a large consortium of more than 50 academic centers, mostly in the US and in Canada, and one of them in Europe. But we are opening up to other institutions now outside the consortium to increase the enrollment. The initial target enrollment was 100 cases, but we will likely extend beyond that number. And we're collecting detailed clinical EEG and imaging data using a very neat system called REDCap, which is an online system where researchers worldwide can access and store and share de-identified data in these kind of multi-center registries. And we're also collecting in a very standardized way biological samples, including CSF, cerebrospinal fluid, serum, blood for DNA, brain tissue, and other samples as well. And all these samples will be shipped and stored in the central biobank at Yale, so we are sure that all the samples are properly stored for future research. So where are we at the moment? We have 23 active centers. 4 are still awaiting institution approval to go on with to start the research. We have enrolled 42 patients, mostly adults, but we're increasing the number of pediatric centers, so we should also start enrolling a lot more children in the near future. Half of these cases qualified as FIRES, so it was NORSE preceded by a febrile episode. A third of them had a proven etiology, and it was mostly autoimmune encephalitis. So 2/3 of them were cryptogenic NORSE or FIRES, and we have biological samples in 37 of the 42 patients. So it's not bad at all. A couple data on the patients we've enrolled so far, and this was presented as a poster at the last American Epilepsy Society meeting in December 2020. Just a few key information: 23 patients receiving immune therapy, and one very interesting finding of the registry is that the median time from admission to receiving immune therapy was 4.5 days, which is actually much shorter than what we have seen in the past. To receiving immune therapy was 4.5 days. Which is actually much shorter than what we have seen in the past. In all the prior studies on NORSE and FIRES, this median time was closer to 3 weeks, even 1 month sometimes. So the field is changing in NORSE and FIRES, and it seems that physicians are much more aware of the probable inflammatory and autoimmune etiology of NORSE and are giving immune therapy much earlier than before. What are these treatments that are given? Steroids, IVIG, plasmapheresis, tocilizumab, and rituximab. No anakinra yet, probably because we have enrolled only a small number of children. I'm expecting that when we enroll more children, we're going to see anakinra in those therapies. Mortality was 30% in this cohort, which is in line with what has been previously published. We have 9 patients who reached a 6-month follow-up visit, all had some form of disability, 7 had moderate disability, 2 had severe disability. But the good news is that those who reached there's a typo there, it's not a 6-month follow-up visit, it's the 12-month follow-up visit. Of these 4 patients, 3 had a very good outcome. So it seems that there is improvement with time, and the more time passes after discharge from the hospital, the better the patients get. So what are the prospects from now? We're going to pursue enrollment up to 100 patients at least, and very likely beyond that number. We're going to run an interim in-depth clinical data analysis. So at the moment we have enrolled the 50th patient, we're going to do a first analysis of the database and see what information we can get for in terms of outcome and comparative effectiveness study of the different immune treatment that have been tried. We've stored samples, and of course we are in discussion and open to share these samples with labs that are interested in running analysis, trying to unravel the etiology on NORSE using genomics, immune, very complicated immune approaches like the ones you've heard about yesterday during the scientific symposium. That's all I wanted to say about the prospective registry. It's very exciting. It's moving forward, and I hope in a year from now we will be able to provide even more information and hopefully some good news for everyone. Thank you very much, and I'm happy to take questions.
I think if it's okay, what we'll do is save questions till at the end of all of the research topics in case there's some overlap between those. One thing I just want to highlight, I think, Dr. Gaspard, this is, since it's prospective, it's for patients in the acute phase at the time of diagnosis, right? So our families that are on today, this isn't one that they would be able to reach out and enroll in. This will hopefully give us answers to the questions that have come up, but it's not one they need to be enrolled in that acute setting.
Absolutely, you're totally right. I should have precised that. You're right.
Thank you. So next we'll have Dr. Gofton talking in more detail about the family registry that you guys have heard about a little bit already.
Sorry, my mute was stuck on. Okay. All right. So thank you. My name is Teneille Gofton, and I'm going to talk about the NORSE Family Registry, which is a group study. We have investigators that many of whom are, all of whom almost are here today, who've been working on this, and Karnik, who's been helping behind the scenes, who has been instrumental in helping to get this launched and keep it running. So the NORSE FIRES Family Registry is just that. It is a registry that is designed to gain information about people who are affected by NORSE worldwide. And the reason is to improve care and see if we can inform future research better. And the other reason and really important thing is that families can contribute, and I will get to that. So we want to try and figure out an idea of worldwide distribution of NORSE and FIRES and what type of short-term and long-term outcomes are seen. And so the main thing that we're expecting is that we will see people affected worldwide if we're able to get a worldwide audience participating, and that we think that the effect of NORSE and FIRES on survivors is usually quite profound. So how does this registry work? First of all, this is a registry that is designed from the get-go with the idea and hope that families and survivors will be able to enter information independent of their healthcare team or with a little bit of help from their healthcare team. It is quite common that we hear, and I've heard it here in the last 2 days, after a hospitalization, The question from family is often, well, there's a medical chart. I really hope that this is being included in a study so that people can learn more about this. And the truth is, if you're not at a hospital that's participating in NORSE research, then that is not going to happen because it has to be part of an ethics approved study. And so with this registry, survivors or their surrogates, meaning family members, or their healthcare teams can help to enter data directly into this database, which we use REDCap for. And that's just the database. The link is here, but we can also put it in the chat afterwards to make it available to everybody. So we're collecting information that you as family members can provide, specifically on things like where the person affected by NORSE lived, how old they were, items from their medical history before they came to the hospital, and things that happened as part of the early presentation of the illness. We're asking some very small questions about the in-hospital treatments that you may need help from your doctor with, but most people will be able to answer on their own. And then we're looking also at doctor-family communication, long-term outcomes. So how are things looking a year down the road? And for survivors, we're also looking at quality of life. So the key features of the survey is that when you enter the survey website, you have an opportunity to provide written and informed consent and to do this electronically. So there's a consent form beforehand, and you get a copy of that emailed to you. It's set up so that survivors, but also non-survivors can have information entered. So it doesn't matter when NORSE or FIRES was diagnosed, if this was 5 years ago, 10 years ago, or 5 days ago. You can enter information into the database. And for somebody who has passed away from NORSE or FIRES, the database asks one set of questions, and then it is completed at that time. For somebody who's a survivor from NORSE, if it was many years ago, it asks questions up until the current time, and then the survey's done. And if it's somebody who's been affected by NORSE or FIRES recently, then it will ask questions right now about how things are, and then it will give you an email in about 12 months and 24 months to come back into the survey and enter some more information on how things are going from the point of view of day-to-day life. Our goal is to have the registry available worldwide if possible, and in the fall of 2020, we've done a revision to it. So we have detailed outcomes that we're looking at. We've also added a couple of languages. So far it's available in English, French, and Spanish, and we are expanding to other languages, but we're doing that as time goes on. So to date, we have 28 participants from 9 countries. This is just to give you an idea of where they are through the globe. So it's been all over the world. The mean age of people who participated at this time is 19. And then the mean or average age of survivors who participated is 10.5 years after NORSE. So 20 out of the 28 participants so far have been survivors, and 21 of those have been a presentation consistent with FIRES. So we're collecting information on both the FIRES and NORSE, obviously. What we've been able to tell so far, and this is a work in progress, is that survivors do have a lot of seizures, more than 10 a month often. All survivors that we have had enter data into the database have epilepsy after the NORSE or FIRES, and that they are taking many anti-seizure medications on a monthly basis or daily basis. Quality of life is something else that we've been looking at that's highly impacted, and I don't need to tell the people on the line here that it's highly impacted, but what we've been able to show is if you rate quality of life from 0 to 10, with 0 being not good quality of life and 10 being the best quality of life, that the rating is around 2.9 for survivors. So it's quite a challenge. And I think the more information we can get about how to manage resources afterwards is really important. So the hope of this registry is that it will contribute to our understanding of NORSE and FIRES overall, but also that it will provide information into the impact of NORSE on daily life, and provide an opportunity for families and survivors to directly enter information. And I saw there was a question in the chat earlier. I can't see it right now, but the question was a common theme that had come up was that people who'd been affected by NORSE and FIRES had been high achieving before the before the NORSE and FIRES happen. And that's one of the types of things we're trying to get at and we ask about in the registry is, you know, are there different elements of the past history that you think are important for us to know about? So if you choose to participate in the registry, that would be fantastic. Anybody who's been affected by NORSE or FIRES is eligible to do that, or their family member to help them, or if they've passed away. And when you go to the website, you can provide your informed consent there, so you don't need to go to a hospital for it. You don't need to be at a doctor's office to do it. And you can sign in and sign out and save your work for later, so you don't have to be able to do it all at once either. And every contribution is really valuable. I know that it will be challenging from an emotional, but also from an information management point of view to go through and do the registry. But if you feel up to it, we'd really appreciate your participation. This is how to access the survey, and I will put those in the chat afterwards. And you can either email Carnegie or myself for further information, and I'll put that in the chat also. Thank you so much.
Thank you, Dr. Gofton, for sharing that. It looks like Carnegie has actually already put the link in, so that will be available for people. And hopefully, you know, if it's something that you feel like you'd be able to do, will help us be able to answer more of these questions moving forward. Next, we'll go. I'm not sure which order you guys are going in, but Dr. Koh or Dr. Taraschenko is going to talk a little bit more about basic science research in NORSE and what they are doing. Dr. Koh, have you started? Sorry, I don't know if you're muted or if you haven't started yet.
I need to be allowed to be unmuted. Can you see my slide?
Yes.
Okay. I will be speaking for both Olga and myself. We were two recipients of seed grant that was granted last year through AES. We're both working on the animal models of NORSE and FIRES. Taraschenko specifically are looking at the known etiology, which is the NMDA receptor antibody mediated encephalitis associated NORSE. And I am working on more FIRES model. And we're just getting started. I would have joined University of Nebraska, where we will be right next to each other. We'll be neighbors in laboratory and we'll collaborate extensively. I'm very excited about that aspect of my move. As we all heard, we have to, when we create an animal model, we try to simulate the clinical scenario as closely as possible. And for a very rare condition such as FIRES or NORSE, I would call this almost ultra rare, therapeutic trial can be problematic because it is truly 1 in a million. And by creating an animal model, you can test and screen for promising therapeutics, and that then can inform future research and clinical trials. And so we look at the salient features of NORSE and FIRES. And for FIRES, there's a preceding febrile illness. Perhaps there's a stress in NORSE that might be triggering excitability. And then following this acute phase, what we see is an immediate transition to recurrent seizures, which is epilepsy. So what we need to know is that whatever animal model we adopt, we have to have these features. Another feature is this long-term sequelae, which is neurodegeneration, cell death, and inflammation. And inflammation, we have talked extensively. There is clearly a role of activated microglia and astrocytes and perhaps T-cell infiltration. And these also will need to be replicated in the animal model. And so what we have seen is this, how do we simulate what we see in clinical scenario? There's this rapid progressive onset of seizures and encephalopathy in a perfectly healthy individual, which then evolve into prolonged superrefractory status epilepticus over a few days. And that is the salient clinical feature. This then drug-resistant epilepsy follows without a latent period. There's this from acute to chronic phase occurs almost without a break. And this, of course, needs to be distinguished from the fever-sensitive epilepsy. And what we did see is these, healthy animals, when we implant a kainate, implant a little needle into the hippocampus itself and infuse excitatory toxin, what we see is this marked microglia activation in the hippocampus and astrocytic activation, but also evolution of very frequent subclinical seizures that's noted by EEG. So the goal that we will try to achieve with this model development is to have a intrinsic deficiency in this break on the interleukin inflammasome, and by using both wild type and this interleukin-1 array deficient mice, kind of genetic predisposition perhaps to epilepsy and to NORSE and FIRES. And by using this model, ultimately what we would like to do then is to develop effective immunomodulatory therapy. And this basic science research will then be partnered with the clinical team, which have been formed already. And both Olga and I are part of the Delphi project. And we have started and evolving now. We're started with Dr. Ronnie Winstrom, who had an A facilitators, and we are along with many others who are here, we are the facilitators, and we have chosen 48 panel members, 25 pediatrics and 23 adult epileptologists, and we're in the process of generating a consensus guideline for the treatment of NORSE and FIRES. But more importantly, this then we have developed this network of clinicians and clinician scientists to investigate further and informed by basic science research. And that's where we are currently.
Thank you for sharing, Dr. Koh, what the research you guys are doing. I think it's great to hear about research that patients can be involved in clinical research, and also the basic science research. So we'll have a chance for a little bit of questions at the end, but we have a few more people to briefly talk. So Dr. Stredny is going to briefly talk about a question that she is trying to answer, and then after that we'll go to Dr. Hirsch.
All right. So I'm going to briefly talk with you about what we are hoping to learn about the use of tocilizumab in FIRES. So to quickly review what's already been done and has been discussed a few times at the conference, we recently published an international cohort of children with FIRES who were treated with anakinra. It was overall well tolerated without a significant increase in infections. A few patients did experience a reaction called DRESS, or low blood counts, but it was only discontinued in one patient because of an infection. Given the retrospective nature of the study, efficacy data was limited, but it was able to show that earlier anakinra initiation was associated with shorter duration of intubation with a breathing tube and shorter hospital and ICU duration of stays. And there's also been a recent case series of a few adults with NORSE who were treated with tocilizumab, and they found that seizures stopped after 1 or 2 doses in 6 out of the 7 patients in this series, although 2 of them did experience serious infections. And our experience in children with FIRES or NORSE and the use of tocilizumab is not yet well established. And so there's been 2 reports in the literature so far, to my knowledge. There was one initial report of 2 children with a FIRES-like presentation who were treated with tocilizumab. And I just recently published a case of anakinra refractory FIRES that was treated with tocilizumab. And we're now hoping to expand upon this to compile a case series of children who've been treated with tocilizumab so that we can increase our understanding of its possible efficacy and safety profile in children. And so we're just embarking on this. And if there's any physicians who would like to contribute de-identified data to the case series of a patient with FIRES who was treated with tocilizumab, I've left my email here and would greatly appreciate hearing from you so that we can try to grow this number and learn as much as we can. Thanks so much.
Thank you, Dr. Stredny, for sharing. Sounds like another opportunity again that will help hopefully answer some of the questions that you guys have asked over the last few days regarding tocilizumab and its use. We have one more person to hear from, Dr. Hirsch, if you don't mind.
Okay, great. I don't have any slides to share, so you can keep it in your gallery view or whatever view you have it on. So I was supposed to talk about the Biorepository. That's basically our future one. So just to summarize, right now there's the family registry, which allows patients or families or their medical staff to enter patients anywhere in the world who had NORSE or FIRES at any time, including 20 years ago. So we have that. Now we have the ongoing prospective clinical study, which only enrolls people who are in the acute hospitalized phase and are in a participating center. But for that, we're actually storing samples. We're not actually doing analyses on those samples. So all that clinical information will be available and published. But the analysis of the actual samples then goes through another round of competitive funding, which has already occurred. So several of the Norse Institute funded projects will be using the samples obtained from that prospective study, including the one by Eric Payne and Charles Howe from Mayo. So that's some of what's already in place. So one of the biggest limitations of our current prospective one is that it's only discrete centers. It's a lot of them. It's 30 centers or so participating. But what we want to do is have a biorepository that will allow us to take samples from anyone in the world. So if there's an acute patient in Latvia or New Zealand who has NORSE or FIRES, we want to be able to take their clinical information and their samples and learn what we can from them. So we are trying to set that up in a prospective fashion at Yale, really with NORSE Institute support and support from Nora Wong. And the plan, again, is to be able to store all those, to biobank them, all kinds of fluid, the blood, spinal fluid, nasopharyngeal swabs, and then to not only accept them, but to actually run some basic analyses on them. I shouldn't say basic, to run analyses we know we want on all of those patients. So we know all of them need autoimmune antibody panels and done in the proper way. They all need to look for infections. So we want to use some of the latest techniques like metagenomics, which will take the spinal fluid and look for any non-human DNA in it. So this is something Michael Wilson and at UCSF has published on, and to be able to find infections you never even thought of, but it will tell you there's non-human genetic material in there, and then you can identify it. And he's published on that for identifying rare infections as causes of encephalitis. So doing that standardly on all these samples, obviously that takes funding to do that. And then we would like to be able to give feedback to the people sending those samples. We want to be able to give the results back. That's actually requires some special certifications of labs and things like that. So we're hoping to do all that. And then the rest of the samples will be stored, and we'll go through a similar process of a competitive type of way of using for other people's research. So again, we've already done it through the American Epilepsy Society and through the National Organization for Rare Diseases, where anyone in the world can say, I want to use those samples, I want to do this kind of research on it, and a panel of experts decides which is the best one to fund for that. We will also hopefully be able to take samples from years ago if they were stored properly. That's just a different type of procedure, of way of accepting that, and certain analyses you can do on old samples, other ones you cannot. And so that's basically it. So the goal is to be able to have one centralized place where we can take samples anywhere in the world, really acute samples and old samples, do these detailed immunologic, infectious, and other kind of analyses, give those results back. All of this will be made available to all researchers. So that's going to be a key component of this, is not only will you take the samples and do your research, but you agree to make all of your results available to other researchers. So we want to make this something that everybody will benefit from, even if they're not the one that got that particular round of funding. So that's the long-term goal that we're trying to set up at Yale with NORSE Institute assistance. And, Nora, did I forget anything? No? Okay.
That was great. That was it in a nutshell. Thank you.
Thank you to everyone for sharing. I was going to say thank you for sharing where we're at with research. I will mention that there's other research projects going on related to NORSE and FIRES that we, did not highlight today. And so I do acknowledge that it's just a sample of the research that's available, and that there are additional projects that will hopefully help answer some of the questions that have come up over the last 2 days. In the last 15 minutes of the conference, I just wanted to open up things for questions again. We have many researchers, physicians, scientists on the line, as well as families. And so this was our hope to have an opportunity of any other questions, ideas for future research. I know there's a few questions that weren't answered yesterday that if we have time, I'll bring those up again. But just wanted to open things up about questions about any of the research projects or future directions. It's probably best, I guess we can unmute you if you raise your hand, or you can type comments into the chat as well. All right, I don't see any questions yet. It may take time for people to type things in, but I will bring up one from yesterday. So there was a question that I think is, there's one that just popped into the chat as well. So I'll get to that one in a second, but one question about most patients and families don't have a background in immunology, genetics, or neurology, and have trouble understanding scientific articles in PubMed. So what resources are available for average families to understand NORSE FIRES in plain language, as well as humanize the scientific findings? So it was a very thoughtful question. Nora, I didn't know if you actually wanted to jump in and answer that one, or if someone else has thoughts about that.
Thank you, Krista. I do. We've placed several articles and guidelines on the NORSE Institute website. The website's divided into two, one for professionals and one for families. I encourage families to go to the family side and start to look at a basic glossary of terms that Erica Sieg put together. She also put together a planning guide, and there are some basic, very basic articles on NORSE and FIRES. But then I think that families should also look at the professional side, because they have articles there that we have curated articles by Nicholas Gaspard. And curated meaning he has listed articles about NORSE and FIRES and why different ones are so important. So then you can take your time to look at what's been published, what you can see, what do physicians look at, and then also look at what other families have felt has been helpful. And then I also would like some feedback as to what resources families have had. You can share with me and I can try to post them.
Thank you, Nora, for giving that insight into how we can improve that piece of the communication. Another question that came into the chat was, has anyone attempted using lipids for treatment in the chronic phase? So asking about omega-3 and omega-6 supplementation.
My short answer is no. Does anybody have anything better than that?
I agree. I've not seen anything with that at this point.
I think knowing that ketogenic diet works for FIRES, perhaps the modified Atkins diet, and thinking that way, there may be some relevance, but I don't think anybody has done any studies. And there's a lot of talks about brain health and how omega-3 is helpful, but I don't think there's any scientific basis for it. But all I can think of is this connection between ketogenic diet versus these lipids.
Thank you. Which somewhat goes into, we had another question about, does keto diet help erase the epilepsy attacks, which I think, we had discussed some yesterday in terms of the different treatments that the ketogenic diet can be helpful part of the treatments considered for NORSE and FIRES. I don't know if someone's trying to raise their hand, asking to unmute. Let's see if I can unmute you. Oh, there you go.
Hi, my name is Breatha. My daughter, we tried the ketogenic diet and it actually aggravated things really, really bad. She started to get paralyzing seizures where her body would be locked for half an hour, and it could take 2 middays to unlock her again. So the ketogenic diet, she got into ketosis, but it was so bad for her.
And of course, it is a very powerful intervention, and it is it changes the entire metabolic pathway, and so diet doesn't mean that it wouldn't have side effect either. I think there are also not only the potential for exacerbate seizures, but I think ketogenic diet has its own attendant side effects, such as diarrhea, constipation, and intolerance of the lipids. So yes, I think it's very much, it's a trial and error for sure.
But with the seizures, she was conscious through them, where her body would just not move. Her fingers would be frozen. It was horrendous.
I was just going to add that I don't know if anyone checked her blood sugar. Blood glucose sometimes can be affected with ketogenic diet, and hypoglycemia or low blood sugar can independently trigger seizures. I don't believe that it can be status epilepticus, but still that's one of the complications of keto diet to watch for.
Okay, no.
May
We
I ask,
didn't stick with it. Sorry.
no, sorry. May I ask a question? The ketogenic diet was tried during the acute phase or during the chronic epilepsy phase?
During the chronic epilepsy phase,
Okay.
I'd say we were like 3 years into it when we did it. And things, it was kind of at a last resort to see if it would work, because the Vegas thing had been put in and that hadn't worked either.
Because the difficult thing during the acute phase is that there are so many things going on that you try a treatment and you're at the phase of the disease where things get worse no matter what you do. So you may get the impression that the treatment does worsen the situation, where in fact it might be helping, but the situation in itself is getting much worse. But it's true that sometimes even in kids treated with the ketogenic diet for epilepsy from another reason, sometimes the ketogenic diet may make things a bit worse. That's not specific to NORSE, I think.
Okay,
If I can just add to that, it's an important point that if you've tried the diet in the acute phase, and we talked about this a little bit yesterday, there may still be a role for it in the chronic phase or vice versa. So if you failed it early, it may still be something to think about. And I followed dozens of kids over the years on the diet, and there are definitely children who get paradoxically worse on it despite good glucose and other things, same as they can get really bad on some of our seizure meds.
Okay.
Thank you for asking your question. All right, it looks like Tori was hoping to be unmuted to ask a question, had messaged and raised his hand as well. So if we can unmute him.
You got me, thank you. Dr. Payne, I think I asked this question yesterday, and you gave me enough of it. I don't know if anyone else has anything to say about it. And it was in reference to children, from what I understood. But I just want to ask it again if I get further thought on it. What is loss of brain volume? And does that have anything to do with, so when this happened to me, I was already turning 21. So is that something that's relevant to an adult? So first and foremost, what is loss of brain volume? And then second, would that be relevant to an adult? Like, so is that something I could get checked for? Like, oh yeah, you still have that. That's why you're acting this way, whatever it might be.
Was the question for me?
Anyone. Dr. Payne answered it in short for me yesterday, but I mean, like you can go further, Dr. Payne, if you would like, but that's anyone for a broad. Dr. Hirsch is actually my doctor, so it's a broad question. Dr. Hirsch, if you know anything about it, whatever, it doesn't matter to me. But yeah,
I can comment on what the very short message I gave back to you. You know, very, very commonly after fires in NORSE, we find that people have lost some brain volume. We use a term called atrophy. It sort of means that the brain is shrunk. I think that's the term I used for you. It means that some cells in sort of a kind of a global fashion everywhere in the brain, some of them are gone, have died because of that acute injury. And there's a spectrum. So some people have a little bit of that, and others have a lot more. Medications probably contributed. How much your seizures were controlled, how quickly they were, that contributed too. There are going to be patients you're going to have to do neuropsychological testing to sort of actually identify problems. There'll be a lot of people who you won't be able to tell that at all. Importantly, it's not progressive. So if it's there, it's not something you need to keep following with regular MRIs or imaging every year. It's secondary to what happened when you were acutely ill in the ICU, and it should not get worse over time.
Eric, Dr. Hirsch, am I still smart?
Absolutely.
Eric, correct me if I'm wrong.
If I'm correct, but Tori, after his entire illness, got accepted to multiple graduate schools and got another degree. So he's on that extreme end of the spectrum of amazingly good cognitive function after a prolonged illness. So.
Eric, correct me if I'm wrong, but regarding loss of brain volume after fires in NORSE, it's not specific to either of those. It can be seen with any prolonged refractory status epilepticus. But importantly, we don't know. We don't know if it's there forever. There is no long-term data, so it might be reversible. It's just that no one really gets an MRI each year after being discharged from the ICU, and we don't see the brain getting back to its normal initial volume. So we see it definitely, but it might not be definite.
You know, I think, again, you're going to be talking about it on a spectrum. You know, some of our medicines can cause some of that appearance on imaging acutely. So for sure, there could be some instances where that's not the case. But, you know, there have been other children who have been imaged with PET and some other more advanced imaging, and there's no doubt that some children experience loss of cells there, and in that instance, that's not going to come back or change. But I think, you know, again, as I say, there's going to be a huge spectrum, and I'm glad to hear, Tori, that you're on the far extreme of that.
Thank you everyone for your answers. I appreciate it.
There's a question about COVID. I suspect several people wouldn't mind hearing an answer on that, but it's my understanding from CDC and virtually every other expert is that having had any of these autoimmune processes is not a contraindication to getting COVID vaccination. And I strongly encourage everybody still to get it. If maybe some of the other doctors want to make any comments.
The vaccine questions comes up with many children with epilepsy, as especially young infants. And I always say they deserve the protection. All children, especially children with epilepsy, deserves the protection that vaccine provides.
Yeah, I often add that when patients get sick with illness, they can have more seizures and an increase in seizures. And so I think it's really important to try and stay healthy to prevent that. And so if any of our immunizations can help with that so that they couldn't potentially be less sick, have less seizures, I think is important. There's a few more questions in the chat. I don't know if anyone, some of those we may answer through writing in as well. I know there was a question from yesterday too about, are there any suggestions for the chronic course of FIRES in NORSE? And I think we covered that one earlier, but if I'm missing what someone was wondering about that question, it's an area that we still need to get more information and research about, and hopefully the registry will help with that. A recent question in the chat about sulfiam in combination with other drugs. Does anyone have experience with that drug and want to answer that question?
Yeah, we use that a lot in Canada, sulfiam. We use it for all sorts of epilepsies. And I think there are certain seizure types and certain patterns we look for. But I think like any of our other seizure meds, it's got a role and it can be very, very helpful. It's usually one that's well tolerated.
We'll do one more question and then we'll wrap things up. There's a question, oops, sorry, I just lost where it went, about side effects of phenobarbital and what might happen after successful withdrawal in a case of FIRES. Dr. Hirsch, I think you somewhat answered this one earlier. Do you have anything you want to add? You're talking about medication levels and that maybe other medications levels are increasing and that some of the symptoms that they are noticing. Do you have anything you want to add to that question?
No, that was the only thing that came to mind. If some symptoms were getting worse as phenobarb was taken off, obviously seizures can get worse. But if some other symptoms like balance or those kinds of things, then it's probably because other medications have gone up, which happens very commonly as you take phenobarbital away. So it's a drug interaction problem, possibly.
Exactly.
Looks like Brita has another comment. If we can, oh, here we go. I can do it.
I just, quick question. Do the seizures improve over time? Like Molly is now this is 5 years. And we have good days and bad days. Do they level out any bit at all, or does it, you know?
That's a good question. That's the kind of thing we're actually hoping these long-term outcome studies are going to answer, because we really don't know. In my experience, it's highly variable. We're definitely seeing some people who don't even have epilepsy chronically. And then obviously many who have refractory epilepsy and none of the meds work and they need brain stimulators or epilepsy surgery. So it runs the whole gamut. I don't think there's any kind of rule that most people get worse or most people gradually get better. It's really highly variable.
Like the felbamate is helping us without a doubt. And when she does have seizures, she's coming back. She's not as, you know, she wouldn't be as confused and that. So that is helping us at the moment.
Good. All right.
Thank you.
Yeah, no, thank you everyone for the questions. And looks like there's a few we haven't quite gotten to, but thank you, Dr. Payne. I know you just gave some information for one of them, so I appreciate that. We'll try and answer the rest of them through the chat as we wrap up. I just want to be respectful of everyone's time for today. So I want to thank you again for each of the speakers and attendees, including the families and medical professionals in the audience for attending our first NORSE Family Conference. I'd really like to thank Nora Wong and the NORSE Institute for all of their help in putting this together and in general expanding our knowledge about NORSE and FIRES. Additionally, thank you to Dr. Hirsch and Dr. Gofton for helping to organize the family part of this conference as well, and the people behind the scenes. So Carnegie, Yash, as you guys have heard us mention already, and then Carol as well, who've helped kind of keep everything going throughout the conference. As Nora stated at the start of the conference, one of our goals was to provide an opportunity for families to learn more about NORSE and FIRES and to connect with and support each other, and also to foster collaboration between families and physicians to help expand our knowledge regarding FIRES and NORSE. It is through these collaborations and increasing knowledge that we will be able to help improve the outcomes and lives of patients with NORSE and FIRES. I know some questions came up about next steps and moving forward, and I want to mention what we have in mind for that as well. So moving forward, we will be working on posting video recordings of the conference on the NORSE Institute website. We also take the suggestions, input, and feedback from this conference and communicate that through the medical community. We also plan to hold additional conferences in the future, and we'll send a post-conference survey to all attendees to help form the future directions for the conference. It is important to continue to build on the support, collaboration, and relationships started over the last 2 days throughout the year. So I'd say let's continue the effort throughout the year and have ongoing conversations and collaboration to move things forward. Nora, I don't know if you have any kind of last thoughts that you want to add at all?
Nope, you did them all. Thank you so much. This is just the first step. Thank you.
I really appreciate everyone. Thank you.
Bye-bye now.
Bye-bye.
Bye.